and thanks for joining us for our video on your questions on the ventilator. So Rose and I are going to talk about, continue our talk on ventilator use, especially in our small babies, and we're going to answer some of the questions, and they were great questions, by the way, that you submitted about the previous lectures that we've done. So to get started, the first question is an excellent question. It's, why is it bad for a tiny baby to stay intubated even on low settings? It's a great question. In the past, what we used to do is let the babies grow on the ventilator. We kept them on low settings, and when we thought they were big enough and strong enough, we would try and take the tube out. Looking at what's out in the literature, and we are trying to use evidence-based research on venting our smallest babies now, it is clear that once the baby reaches certain criteria, it is better for us to extubate them and put them on some other respiratory modality, like CPAP or CPAP. Rose has a whole list of things that can happen when a baby stays intubated.
Yeah, just a few of the things: stridor, subglottic stenosis, tracheal edema, granulation of the tissue, infections, tracheal malacia, pneumothorax, volutrauma or barotrauma, increased ROP, prolonged vent association comes with higher risks of mortality and morbidity, including upper airway injury and infection, BPD, increased risk of neurological impairment. And that's just a few of the things that I found in some of the literature out.
So that's why we've been trying to come up with some criteria that we can all use to see if the baby is ready for extubation. Some babies, this criteria is working great. Some babies, once they meet criteria, they still fail extubation. So this is still a learning process for us. But what we do know is that the faster that we get a baby extubated, the better. For some babies, especially the smaller babies, it could be 3 days, or it could be 3 weeks. So each baby is different, but our goal is to get them extubated as quickly as possible. 2, this is the second question. Can we make it a standard that the provider, the nurse, and the RT all discuss the respiratory plan together? Yes, this is a great idea. Great question, great idea. We are discussing in our group coming up with a way to discuss daily at each bedside with RT the plan for the day, get some input from the nurse, get some input from the RT, and make a plan together. That's our goal. As you know, sometimes it gets a little crazy every day, and so it's a work in progress. But yes, we are also trying to have meetings with the admission nurse, RT, and the admitting physician or NNP prior to an admission if we know it's coming. If we know a small baby is coming, we're trying to have a little huddle before the admission to come up with a plan. And we are also trying to have a huddle with the provider, the RT, and the nurse when we plan to extubate. So I think it's a great idea for the 3 people to meet daily. Rose?
It would be very helpful for the therapist if the nurse would call us when the doctor comes to her bedside, because unfortunately we have all 4 rooms to take care of, so we're running around, and we may not even know that the doctor's rounding in there. So please feel free to call the therapist. If we don't have time, we'll tell you. If we do, we should come and be involved.
So it's a great idea, and it is in the works, and we have heard you that you want to be more involved, and we're going to try and make that happen. What is barotrauma, and is it reversible? These are all such great questions. So barotrauma is exactly what it sounds like. There's 2 types of trauma that can happen to the lungs with mechanical ventilation. One is barotrauma, and that's from using pressure. The baby, if you use, even if you're using adequate amounts of pressure, you can still cause damage. The other type of trauma is volutrauma. It's when we're using volume ventilation now, and we can use the incorrect volume. Anything that is causing the alveoli to be expanded, overexpanded, can cause trauma to those alveoli. And that's what volutrauma is and barotrauma. Once that damage happens, no, it is not irreversible. it is causing scarring of the lung, and it's leading to BPD, bronchopulmonary dysplasia. Rose?
I agree.
So one of the terms, talking about barotrauma, that you will hear all the time is that we'll look at an x-ray, and when we talk about x-rays, we'll discuss this further, is that the baby, especially small babies, have something called PIE. And if you look at an x-ray, and you'll be very good at this after we do our x-ray interpretations, of looking for PIE. PIE stands for pulmonary interstitial emphysema, and it's just like the emphysema that old people get. We are causing that emphysema, or the breakdown of the alveoli in the lungs, kind of a generalized trauma throughout the lungs, that is causing little micro air leaks. So you know a pneumothorax is a giant air leak, right? So there's air outside of the lung. That's why it's called an air leak. PIE are millions of areas that are micro air leaks, and those alveoli have burst and are now going to be made into scar tissue. So when we see that there's a lot of PIE, we know that we've caused a lot of damage. So that is usually caused by barotrauma, too much pressure, or volutrauma, too much volume. And that's what we're trying to prevent. So, next question. Can it be harmful to give surfactant? Why don't we give it to all premature babies less than 30 weeks? Good question. We used to give it to all babies less than 32 weeks, figuring that all babies less than 32 weeks were surfactant deficient. So why don't we just help them out and give them surfactant? But surfactant also has its side effects. Rose?
After a little literature search, I came up with some side effects. The one that we see most of the time is just plugging up the ET tube, where we have to bag a little harder to get it to go down. You can also have bradycardia with desaturation. You can have tachycardia. Big problem is pulmonary hemorrhage from right to left shunting. You can actually have increased PDA problems. You can increase your ROP issues. You can cause volutrauma, and you can cause hyperventilation. And that's part of the reason why once we give it, somebody should remain at the bedside and monitor the baby. And if suddenly you have better compliance and your chest is moving better, we need to start weaning the ventilator.
Exactly. So, also one of the issues with surfactant, if we give it to everybody or we give it in the delivery room, we're not exactly sure where that ET tube is. So sometimes that ET tube can be down the right main stem. And if you'll look at an x-ray, sometimes you'll see that the right lung is way overinflated and dark black, and the left lung is way underinflated and is basically whited out or looks like it's got RDS. That's because all of the surfactant went down into one side. So here we have a lung that's susceptible to barotrauma and volutrauma, and this side is not working very well because it didn't get any surfactant. Also, the use of surfactant has gone down in recent years because of a huge study that was done that showed that babies that got CPAP in the delivery room, were transported on CPAP, and were placed on CPAP in the NICU, did better than the babies who got surfactant, probably because of the side effects that Rose just talked about. And those babies ended up having less BPD. So as a group, we have decided that if you're 26 weeks and above, that you're going to get just CPAP in the delivery room. You'll be transported on CPAP and you'll be placed on CPAP once you get into the NICU. If you're 26 weeks and below, then you will get surfactant in the delivery room. So what we're going to try and do is we're going to do what we just said. 26 weeks and below, you get surfactant in the delivery room. If you're 26 weeks and 1, you're going to just get CPAP in the delivery room. That's not to say that those babies won't fail just CPAP and end up getting surfactant in the NICU, but we're going to try this and see how it works for our unit. Anything else?
I think that about covers it up.
Okay. So the next question is, I have noted that the same, and they put PIP, but I think they meant PEEP, cannot be reached with the mask and the prongs when using the same input from the machine? Is it appropriate for the RT to make adjustments accordingly?
And the answer is yes. And I'm pretty sure with this they're talking about CPAP or CPAP with the blue machine. And the prongs will restrict the flow, so it may change how much the baby gets. So it is fine to call your respiratory therapist to come and see if they do need to make an adjustment. Also, the fit of the mask and the prongs is really important. If you have prongs that are too small, then you're going to either have air blowing out, or you're going to pull your mask too tight, and then you're going to have damage to the face. Same with the mask. If your mask is too big, then you're going to have air leaking out around the baby's eyes. If it's too tight, you're actually going to end up occluding the baby's nostrils and make it difficult to breathe. But anytime there's a change that you're uncomfortable with, call respiratory and have them check it out. If you're not sure of the size, mask or prongs, call the therapist and they can help you decide what is the correct size for the baby. But remember, for the prongs, it should be the largest size that easily fits into the nostrils. That's the only way you're going to get a good seal. If you use a smaller size, you're going to end up pulling it tight, and then you're going to start having the damage to the face.
So if you have a set of prongs that are easily in the nostrils and that you can see area around the prong itself, there's a gap between the nostril and the prong. Would you try a bigger mask? I mean, a bigger set of prongs?
Yes.
All right.
There are times that I've taken a larger size and tried, and they don't fit because the baby might be in between. But it never hurts to try, and I don't mean force them in. Try. If they slide in easily, that's the right size to use. If they don't, then save them for later. You might need them later, but then use a smaller size.
Okay.
All premature babies do not need extra small prongs. Totally depends on the nostril size.
So a baby could have a mask size that's medium and a prong size that's large.
Correct.
Okay.
And any baby that's been on for an extended period of time, chances are their prong size is going to be bigger. No matter how careful we are, there is going to be some stretching of the nostrils. So don't get all upset if your baby is tiny and has large nostrils. It's just the way it is.
Okay. Excellent. So, can we do more X-ray interpretation? Yes, yes, and yes. I've noticed that many of the nurses have started looking at the X-rays of the baby's daily X-ray, which is awesome. I am going to do a lecture as soon as my videographer comes back for her college Xmas break. We're going to do an X-ray interpretation video. But in the meantime, when you see the provider, the doc or the nurse practitioner coming around in the morning, pull your X-ray up so that we can discuss it. What we're trying to do now, what I'm trying to do anyway, is to try and get my morning X-ray after change of shift, so that the person who's taking care of the baby knows exactly where the ET tube is. They're the one who held the baby. They know what's going on, and that we can discuss it together. The ET tube placement, the line placement. Is the baby having any kind of atelectasis? Do we need to position the baby different? You can tell me about having to suction the baby. It's a great place to start talking about the daily plan. So yes, we are going to do more X-ray interpretation.
And I would suggest before the X-ray is taken that the nurse actually looks and sees where the ET tube is at the lip. So when you look at it with the doctor, you can say it was at 6. And then if the doctor says it's too high or too low, you'll know where to adjust it to. So it's really important to look at the placement right before the X-ray.
Yeah, you're going to be holding the baby, so you can make sure at the time of the X-ray you can see exactly where that tube is. So don't go by what the person at night told you. Don't say the tube is taped at 6 or the tube is taped at 7 at the lip. Don't take their word for it. Things change. The tube can move with suctioning or with the baby moving. Just make sure you know when that X-ray is taken exactly where that tube is so that we can adjust it if we need to. All right, so can you explain when, why, and I think this should be PEEP, is ordered to be 6, varying between 5.2 and 5.8 is not acceptable?
So I'm thinking we're talking CPAP and CPAP again. And basically, it is acceptable. When a baby breathes in or then exhales, you're going to see different PEEPs each time. So a little variation is fine. If your baby's on CPAP of 7 and it's reading 6.5, 7.1, totally fine. If it's reading 4, then you got a problem. If it's consistently not reading what the doctor wants, that's when you need to talk to the doctor or talk to the respiratory therapist and see if we need to make some adjustments, whether we need to give you a chin strap, whether we need to change the size of the mask and prongs. But there definitely should be some variation. You should not always see it set at 6 and staying at 6 all the time, because that's not normal with breathing.
So it is going to fluctuate throughout the day based on what the baby's doing.
Definitely.
Okay. So if the CPAP is set at 6 and you see 5 to 6.5, that's acceptable.
Yes, as long as the baby's doing well.
Okay. So that's another thing. So if I've written for a CPAP of 6, and you've noticed that all day this baby's been on a CPAP of 5, or it's been reading 5, and the baby's doing fine, the baby is in room air, or the baby's breathing comfortable, you had a blood gas that looked fine, we can talk about that. The baby's on CPAP of 5. Okay, I can even change my order. If the baby is on a CPAP of 7, and you're hitting CPAPs of 4 and 5, and the baby's failing, then you have to call respiratory therapy and figure out what's going on with the baby. Is that fair to say?
Definitely.
Okay, so if you see any kind of increase, and if you're noticing that when you change from the mask to the prongs, or the prongs to the mask, you're losing pressure like we talked about before, definitely bring RT in, because something could be going on with the baby when you do that, or it could be that there's something wrong with the way the mask and prongs are fitting again. So it all kind of circles back to it could be mechanical and not the baby. So let's fix the mechanical first. Okay. Okay, here's a hot topic right here. This is a big question. Why don't some doctors or nurse practitioners use sedation with intubated babies? That's a great question. So, if you look in the literature, you will find many, many papers on opioid or sedation use in premature babies on the ventilator. Between 1997 and 2007, the use of sedation basically skyrocketed. And so a lot of studies started looking at, is it necessary? Are we over-sedating these babies? Are we using too much opioids? Are we using too much Versed to sedate these babies? And the answer came back, yes, we are. So sedation can cause a lot of problems with babies. It can extend the use of the ventilator. It can cause dependence. It can cause cognitive issues later in life. So when we are giving some type of treatment to a preemie, we always have to think about how is this affecting them neurodevelopmentally. So the pendulum kind of started to swing back the other way when all these studies came out in 2006 and 2007 looking at are we over-sedating these babies? Other means of sedating the baby, positioning the baby, making sure nothing mechanical is getting in the way. Does the baby need to be suctioned? Does the baby have an IV infiltrate that's causing the baby to be in pain and is causing them not to tolerate the ventilator? Are other things going on that we can do to help the baby settle into the ventilator? That being said, it's not a blanket way to treat babies. You have to look at each baby individually. We all know that there are some babies that when they get intubated, they just don't settle into the ventilator. That's where you become important in determining how we should treat this baby. We need to know this baby is not in synchrony with the vent, meaning he's fighting the vent. His oxygen requirement is way up. He's trying to overbreathe the ventilator. Some babies just need some sedation. They may not need continuous sedation, but they will need to be sedated. So, what we, I think, as a group have started to do is to wait and see if a baby actually requires sedation. And if they do, I think that we are trying to move towards using morphine, which is a longer acting drug. Personally, I am more comfortable using fentanyl. That's how I was trained, and that's what I use the most. But I am starting to move towards morphine based on the studies that have been coming out about sedating babies. So, Yes, we are using less sedation. You are correct. But I think that we also need to be told from your standpoint if a baby needs sedation. If there's something else we can do to try and get the baby to settle in, we would rather do that. But we also understand that some babies need sedation. Rose?
Yeah, you can always call the respiratory therapist to see if there's a ventilator problem, or we can usually tell if it's the baby fighting the ventilator, and then we can go with you to talk to the doctor and say that we need some kind of sedation.
One thing, though, that has changed a little bit is that when a small baby is on the jet, we do want them breathing on their own as well. Babies can breathe on their own as well without fighting the ventilator. If they are breathing comfortably on the ventilator, the high frequency ventilator, then that's fine. However, if they are overbreathing the ventilator and not letting the jet do its work, then I think the baby might need a little sedation, either with morphine, fentanyl, or maybe some other type of sedation, such as wrapping or positioning or trying to calm the baby down.
On the jet, a good tell for that is if you look up at the measured PIP, if it never stays stable at what is set, if it's up and down constantly, it's usually the baby.
So we need to know that. You know, we're not at the bedside. Sometimes we'll come by and the baby is sleeping. So the baby looks great to us. Yeah, he's perfectly fine on the ventilator. And as soon as we leave the room, the baby wakes up and becomes, you know what he becomes. He needs to be sedated. So you have to let us know. You have to let us know that the baby is up in their oxygen, or the ventilator can't capture the baby, or the blood gas might be a bad blood gas because the baby is just not settled into the ventilator. And then we'll see if we can do some sedation. Anything else?
Nope.
Here's a very good question. How should I put the circuit of the ventilator? Rose?
So when we're talking about the conventional ventilator, the most important thing to do is keep the temp probes pointed in the right direction. The Fisher-Paykel heater works by two probes that the temperature is supposed to be balanced between them. If the probe closest to the baby is upside down and water sits on it, that's going to cool it off, and it's going to start heating itself higher to try and compensate for that, and you're going to get a ton of rain out. So whenever you reposition your baby, you should look at that probe, which is about 2 feet down from the baby in the blue circuit. It should be pointed down. If it's turned up like this, water's going to sit here and you're going to get a lot of rain out. So you should try and position it so it's always pointed down so water can't sit on it. If we're talking about the jet, you are going to see more humidity in the circuit, but too much will cause a ton of problems. So Bunnell himself, if you go on his webpage, recommends that you take all the extra jet tubing and you put it inside the bed. The more tubing that fits in there, then you have your room temperature and you have the temperature in your humidifier, which is different. So you have less condensation if you put most of the tubing in the bed.
So which tubing are you talking about? The blue and white tubing from the go to the ET tube, or that clear tubing with the blue and white wire that comes into the jet?
Yeah, that's the one.
The clear one.
The clear one with the blue wire in it, as much as possible, should be pushed in the bed. And I always try and put it clear up at the head of the bed so it's not in the nurse's way. But the more of that's in the bed, you'll get less rain out and you'll have less water to deal with. I'm not saying you'll get none, because there's always going to be some, but you will have a lot less. If you leave it hanging out like this, you will start to see down here, you'll see the water swishing back and forth. It's too much water.
And we're going to have a picture for you. We're going to put a picture for you to look and see what the water looks like in this tubing. The water that collects in this tubing can be emptied, but the tubing has to be disconnected from the jet in order to do that. So that has to be done by RT. So call RT when you see the water, and it's going to be in a picture that we're going to show you. When you see that much water in that tubing, call RT and have them empty it, because the jet is not going to work very well with the baby. We just had a baby who had a tubing full of water. Once we got rid of it, the baby started jetting much better, and oxygen requirement went down. So it is a mechanical issue, and it's going to be something that you have to keep your eye on. When you have a baby on the conventional vent as well, if you have a lot of the tubing outside of the vent, you'll get water that is collecting in the bends of the tubing. That can sometimes trigger the ventilator to, they think that that oscillation of the water going back and forth can sometimes trigger the vent to give a breath to the baby. So make sure that that water is out of your tubing several times a day. How often should they check for that?
Just look at it when you do your hands-on. Just like respiratory, the therapist should look every time they do a vent check. That should be part of the vent check. And it also can cause a problem in your CPAP, CPAP. If your PEEP is reading high, it's probably water. There's that big white tubing that comes out the end of your generator on your CPAP, CPAP. That collects water, and I've noticed that some of the nurses are putting a little bend in it. You're changing your oxygen amount by having that there. It needs to be set so the water drains out. And I know it drains out outside your bed, and just put a diaper or a drop cloth or something underneath it. But as long as the water in any of our tubing stays in there, it affects the baby's breathing.
Okay, so that's another thing to think about when you have a baby on CPAP, CPAP, or a conventional ventilator, or on the jet. Water in the tubing, we need humidity in those tubings to humidify the airway of the baby. It's very important. But too much water and the pooling of that water can really affect the mechanics of the ventilator or the CPAP. So you really have to keep your eye out for that.
It's especially important in the jet because the water you see at the back end of it is going to eventually work its way and spray down into the baby. And there have been many occasions where the nurse will say the baby has bradyed and they don't see why. Probably a good amount of those are the water spraying into the baby's lungs. So it's not acceptable to leave it there. It is something that I will once again go over with the therapist and make sure they all know how to empty it out. You do have to take the baby off the jet, so it is not anything that the nurses should be doing. And you may have to help the therapist because most of our babies on jets are only getting like 5 breaths on the conventional. So if we take off the jet, they're only getting 5 breaths. You may have to bag the baby. But it has to be done. And usually if I do it once a shift, that's all I need to do it.
Okay. All right. So this is a very important thing about the jet ventilator. And I know it's something that the nurses look at a lot and they've been asking questions about. So the question here was, or asked to explain the use of servo pressure with the jet. I'm leaving that to you.
The driving pressure that actually determines the flow going to the baby. It's not like your mean airway pressure or any other pressure that you set a certain pressure or you expect to see a certain pressure. It is whatever the machine needs to ventilate that baby. So the bigger the space, the higher your servo is going to be. So if you have a term baby, your servo pressure may be 2, 3, even 4. If you have a tiny baby, your servo pressure is going to be lower, usually 1 point something. The big thing what you have to look for is the change in your servo pressure, because as the lung gets smaller, your servo pressure gets smaller because it's having to ventilate less space. So if you're noticing your servo pressure is getting smaller and your baby's having issues, you probably need to suction your baby. It probably means that there are secretions causing a problem, or it could be your tube is bent, or anything that would make the machine ventilate a smaller space.
So a baby that's coming fresh out of let's say a tiny baby coming out of the delivery room, they've just gotten surfactant, they're 24-weeker, they come over, they get put on the jet. The servo pressure when they get put on the jet is 1.2. As that surfactant starts to work, their lungs get to be more and more compliant, and they get bigger and bigger. So their servo pressure will go up because the volume is bigger.
And that's something that we should watch for too, because in that case, we might need to wean the baby because we might be giving them more pressure than they need because now their lungs are more compliant. So we're going to have a picture also that shows a little drawing of the lungs and tells you exactly what to watch for and what can cause the servo to increase or decrease. But remember that there is not a set pressure that works for any baby. It's all different depending on the baby and also depending on the settings. So if Dr. Hino comes and says she wants her baby's jet rate changed from 420 to 360, my servo's going to change. So you have to get used to that new servo before you actually see a change. So with any vent change, the servo will change some.
So an increase in your servo pressure could be good because the baby's compliance could be getting better.
Correct.
It could be bad because there could be now a leak somewhere in your system around the ET tube, somewhere in the baby, like a pneumothorax. So it's the change that you're looking for. And if it's a dramatic change, then someone needs to
Somebody needs to call respiratory to look at it or call the doctor to look at it.
Okay. All right. So I see some of these things. If your servo pressure starts to go down, that could be an obstructed ET tube, like you said. That would be a small change. If you have a huge change, it could be something big like a pneumothorax.
Correct.
Okay, so a pneumothorax can cause both an increase of your servo pressure
Followed by the decrease.
and then followed by a huge decrease as that pneumothorax gets bigger. Okay.
And if your tube starts to come up and is got a big leak around it, you're going to see the servo pressure increasing. So that's one way to tell if your baby might be close to being extubated. If your servo starts getting bigger and you check your tube and it's not in the right place.
So a big baby who's on the jet because he's got meconium aspiration could have a servo pressure of 4 and be fine. And a baby who's close to extubation, who's a tiny baby, could have a servo pressure of 1.2. Both can be fine for each of those babies. It just depends. You're looking for changes in your servo pressure. Okay. And the number one, would you say the number one cause of a decrease in your servo pressure would be the baby needs to be suctioned?
Yes.
Okay, we're going to have a picture for you that kind of explains this. It's going to have some servo pressure decreases and that gives you a list, and some servo pressure increases. And then we can talk about it more at the bedside if you have a baby on the jet as well. So those are all the questions that we have. So if you have any questions about high flow or changing from CPAP to high flow or any other questions, please let Sonia or Nina know. I'm coming up with another video for x-ray interpretation that should be out by the beginning of the year. And if you have any other ideas that you want us to have a video, please let me know, and we'll try and get it done.